welcome everybody. This is Dr. Thestrup, and today I wanted to go over our medical minute on the new pain control protocol. First of all, kudos to the person who brought this up, because all of a sudden we realized, hey, we don't have a pain control protocol. We probably should have one. So excellent work for bringing that up to whoever that was. I really do appreciate it, but here you go. So let's cover it really quick. So obviously, we have the treatment protocol written here. One of the things we always should document is the pain scale and then monitor vitals every 5 minutes. That's pretty much standard of practice for any patient. We do have a note here about starting fluids. Only provide the fluids if you really need it, and then you can escalate to the amount of fluid that you need. And obviously, during certain conditions, you may want to use the warmer for the fluids as well. And then, really at that point, it's kind of up to you to decide where we are on the pain scale. So mild pain, less than 4. Consider acetaminophen, 1 gram PO. Obviously, that's without any contraindications. First of all, if someone's got cirrhosis or liver failure, you don't want to be really necessarily giving them acetaminophen. And also for peds, you got to look up the right dosage because that could be a toxic dose. For moderate to severe pain, we're going to call this a pain range greater than 4. For non-traumatic, our primary is going to be fentanyl, 1 mic per kilo, 300 mics max dose. What I tend to do is give about 100 mics and 100 mics and then 100 mics and do that. It works pretty well, and you can escalate as you need it. And just remember, with pain medications, you can always give more, but you never can take away. So if you happen to give too much, then that's an issue. We do have an IM protocol for fentanyl as well. And for those of you out there, what are the benefits of fentanyl over morphine? Well, it doesn't have that histamine group that morphine has, right? So that histamine group can actually drop someone's pressure. So fentanyl tends not to drop someone's pressure too much. Now, with that being said, if they're profoundly hemodynamic unstable, yes, it can drop your pressure. In trauma, what we like to prefer as our first line, because it's a little more hemodynamically stable, is ketamine, and that's 0.2 mg per kg IV-IO, max dose of 25 milligrams. And this can be repeated up to 3 times total every 10 minutes. So you can also give ketamine with it, fentanyl with it, and vice versa. It's just a matter of how your patient's doing and how hemodynamically unstable they are. Obviously, if we have a really bad trauma patient that's bleeding out, start the blood. That's your priority. Get the blood going, get them stabilized, and then obviously start addressing the pain as well. Lastly, here we have the nausea and vomiting medication, Zofran, 8 mg, IV-IO, IM. With Zofran, we used to give it prophylactically, and some of you may remember this whenever we gave pain medications, but we don't do that anymore. They actually came out with a bunch of literature saying don't do that. So only give it if it's really needed. If they are nauseous and they are vomiting, then provide the Zofran. Remember, get your pain scale checked after you give the pain medication. That's going to give you an idea of where the patient is. Obviously, we don't want to completely sedate the patient so they're no longer cautious. Then you've really kind of defeated the whole purpose of controlling the pain, because you'd like to continue getting good assessments. The controlled substance form needs to be filled out ASAP after any care has been delivered. Remember, peds dosing, go to the pediatric chart. You do not give adult doses to kids. And that's really about it. If there are any questions, as you guys always know, reach out to me. And otherwise, I will see you next month for the next Medical Minute.